Thank you very much, Brian. It's a treat to work with you and your staff at ISQua. Tina Foster and I will be leading this session, but we're deeply grateful to Glenn Robert and Lotta Arvidsson to join us, and to the entire team from Dartmouth, Jönköping, and Northwestern University here in the US. We have a tightly packed hour to work together. We appreciate your willingness to let us work in English, our first language, even though I recognize that might not be everybody else's first language. And we'll try to use our slides in a complementary way, not as a way to try to introduce a second theme as we're talking, if we use slides, but we'll also just try to talk directly to you. This is a time when we're all stressed with this pandemic and what it does to the way we live our lives in and around healthcare services. What we're going to be working on is this exploration of the underlying knowledge and skill and habits that are involved in the co-production of healthcare service. And as you think about what we face today in both a personal health service need and as a public health service need, you realize that this distinction between personal health and public health is in some ways an artificial distinction, even though we have lived in that distinction in many ways. Today, we face the need to find a way to put these things together. Today's particular aim in this general idea of co-production is to explore the lived reality and what goes on when we try to deeply understand the lived reality of the person that we sometimes know as a patient. Tina and I will work on timekeeping together so that we actually stay on time, and we'll try our very best to live within the hour. I'm going to switch to my pictures, and I'll work with those as we go forward. Our whole team and their names are listed here. This is part of an effort that we call the Co-Production Commons, and this is a presentation and discussion format for this overview of the co-production of healthcare service. And our aim, as I said, is to explore and to open implications of things. We've got a plan for learning that we've put together, and we're in step 2. The first of these sessions that we had was in June with Jean Nelson and Peter Lockman and others, Glenn Elwood. And so what we are doing today is this exploration of an empathic understanding of the person we sometimes call a patient. These people in the Netherlands, in Nijmegen, suggested that we ought to use a different way of describing a familiar role and person's name. We're in the habit of talking about patients. They suggested we should think about TIF caps. We should take a lesson from the musician Prince, and who said at his, after he was in this conversation with Sony, he said, well, there is no person by the name of Prince any longer. You mean the artist formerly known as Prince? And he said that they should refer to him as TAF caps. And what these people in Nijmegen said, you know, maybe we need to pay attention to TIF caps, the individual formerly known as patient. So we're going to be exploring step 2 today. And as we go forward, Our assumptions, and there are many of them, but just a few of them. The first of these assumptions is that a person's health is really not easily outsourceable. It's our health. It's not our doctor's health. And healthcare work is fundamentally a service, and service making involves a logic which involves two parties. It's not a matter of being nice to involve both parties. It's a matter of paying attention to the fundamentals of making a service. And co-production, as Eleanor Ostrom and her husband and others suggested, co-production is fundamental to service creation and service development. Many have picked up on this in many different ways, but these three assumptions are deeply underneath our understanding of the co-production of healthcare service. As we begin to open some of the implications of this understanding, we realize that value creation, and goodness knows we're working to try to find ways to do more with less today, but value creation and its study really requires models that are connected to these assumptions. We can't use value creating logic that we use for making a product for making a service, if making a service always requires these two parties. So as we were thinking about this work of co-production, we realized that that work lives in the context of other quality making activities. And Tina and I were exploring over the last 100 years or so how we might think about that work. Quality 1.0 or Q 1.0 really worked on the question, how might we establish the threshold for good healthcare service? And we used tools and themes like standards and inspection and certification processes and guidelines. And that really helped us make great gains in the quality of healthcare service. But about 40 years ago or so, we began to notice that quality making outside of healthcare, largely in enterprises like automotives and airlines and communications, that they were focused on thinking about quality making as an enterprise-wide effort. And so we began to work on a different question. It wasn't how might we establish the thresholds for good healthcare service, but our new question was how might we use enterprise-wide systems for the best disease management. And we began to explore systems and processes of work and their reliability, and customer and supplier relationships and performance measurement. And it seemed like there was a lot that we could learn by applying some of these new tools and new insights against this new question. But about a decade ago or so, we began to think about, so, all right, we've learned a lot in the last 20 or 30 years. Do we know what we need to know for the next 30 years? Or has the question changed? Is the question now much more like, how might we improve the value of the contribution that healthcare service makes to health? And there were some new themes that invited as we began to explore that question. And so there are things that go between all of these three eras or three clusters of activities. And as we moved from 1.0 to 2.0, we didn't stop doing 1.0. And as we move from 2.0 to 3.0, I don't think we'll stop doing 2.0, but it's a matter of learning in still another way about this challenge of trying to improve quality. These enduring themes or possible issues that cut across have several things in common, but our objective today is not to sort of just think about all the things that we have in common. Our focus today is around 3.0 and beginning to open 3.0. I think it's helpful to think about co-production of healthcare service as being driven by 4 streams of knowledge that underpin the construction of a co-produced healthcare service. We're going to focus on that first one, the blue one at the top, where we're trying to get at an understanding of the lived reality of the person we sometimes know as a patient. And if we took a co-produced healthcare service and put it under a microscope, I think we would see a relationship and some action that was coupled together. And it was being held together by knowledge and skill and habit, some degree of shared power, a willingness to be vulnerable, because you can't really form authentic relationships without that willingness to be vulnerable, and engagement, taking action in an active way. But that doesn't occur separate from a context where there is a supportive system and an interest in design and design science and a sense of agency or entitlement to get on with it. And that's not just for individuals, but it's also at the macro system level as well that we see that playing out. But let me just pause for a moment and see if there is a question or two that we ought to focus on. Tina, do you?
Yeah, Paul, we had a question very early on about sort of the relationship between personal and public health and the education system. And I think that's a very interesting question as we think about how Quality 3.0 kind of expands and broadens our thinking about health.
Yeah, well, for me, the work of the Rockefeller Foundation and others explored this idea of the development of this schism between public and personal health. And over the last century, what we saw happen with the separate funding for schools of public health was the development of an entirely different faculty that focused itself around public health, and an entirely different faculty that focused itself around personal health. And what they were suggesting is that we have to find bridges. Now, they thought that epidemiology would be a way to do that. I think that's one of the ways, but thinking about systems is another way. And another way still is, I think, what gets introduced when we start to understand that these are people that are involved in this work. People who are sometimes known as patients and people who are sometimes known as professionals. And that common understanding of working with our kin or our kinship, it offers, I think, still another way to bridge this connection between what we have historically, at least in the last century, tried to separate off as a public health or a personal health kind of thing. But maybe I'm not responding to the sense of the question, right, Tina?
No, that sounds like an excellent response to me. And I think, again, the connection as we think about how this invites us, if you look at that image there on the slide of sort of inviting this idea of co-production of health really into the community, which would touch on things like our education system. We also have a question about who can lead co-production. Seniors, Sarah asks.
Well, I think the people who are involved are great leaders of co-production. And I think if you're in the co-production of healthcare service, you actually do lead the co-production of healthcare service. And when you're outside of that direct activity of co-producing the healthcare service, you lead by studying the phenomenon or enabling the work that's going on. But Glenn Robert, who's now moving up toward 2 decades of work in trying to understand this phenomenon of experience-based co-design and a deeper understanding of how persons who are sometimes known as patients live their lives. And I think we ought to give Glenn a chance to talk about this. So let me stop sharing my screen and let him pick it up from here. Welcome, Glenn.
Thank you very much, Paul. Thank you. Right, just let me share my screen. There we go. Hi. So thanks, everyone. Pleasure to be here. It's a sunny afternoon in London in about 2000. And the work really emerged back in 2004, 2005, when colleagues and I began to think about what design thinking could bring to quality improvement in healthcare. And we were struck by the way in which designers think about designing a product or a service and the 3 components that make up an ideal product or service. And they talk about, and this is from Scott Burcombe's work, the noble idea of these 3 components of performance, engineering, and the aesthetics of experience.
Okay, back to you, Glenn.
Okay, hopefully that's better. Sorry about that, everyone. So yes, we were struck by how designers think about an ideal service or product and these 3 components of performance, engineering, and the aesthetics of experience. And what we were struck by was that a lot of quality improvement work at the time was focused very much around performance. So our healthcare service is functional, efficient, do they deliver what they're supposed to deliver? And we had quality improvement approaches such as Lean, which helped address those types of issues. The second component around engineering, around is it safe and reliable? Again, back in 2004, 2005, increasing focus on patient safety and interventions to improve patient safety. What we noticed, though, was that this third component around the aesthetics of experience, what does it feel like to be either a user or a provider of a healthcare service? And it was here that many quality improvement approaches didn't really seem to be attending to this third component, both in terms of the physical environment and the human environment, the relational interactions between. And it was here that we thought something like co-design might make a contribution. So what we came up with was this creative process through which patients and staff could work in partnership to improve services and or develop and evaluate interventions. It wasn't just about understanding, but also responding, having the capacity to respond to another's feelings. So there's these 2 components to empathy, both understanding, but also being able to respond appropriately. And we thought there might be value in integrating some of the human-centered tools and values of co-design into quality improvement work in healthcare services. And the distinctive features of the approach that we developed and piloted and have been working with since 2004, 2005, 2 of those. One is a focus on designing experiences as opposed to just systems or processes. Systems or processes are, of course, important, but if they want to attend to this third component, then we may need some different methods and tools and approaches, such as ethnographic methods, so narrative storytelling-based approaches, and the use of much more observation of day-to-day interactions in healthcare services. So that's the first distinctive feature. And then the second around, a direct user and provider participation in a face-to-face collaborative venture to co-design services. So this was about bringing staff and patients together as partners to identify improvement priorities in the services that they shared, and to then work together to identify solutions and implement changes, and indeed to evaluate those. And so there's a paper in Quality, Safety, Healthcare back in 2006, which sets out some of the sort of underpinning ideas. And I'm not going to have time today to go into the detail of the experience-based co-design method, but there is a free-to-use online toolkit. You can see the link on the slide here. It sits on the Point of Care Foundation's website. So what we developed, in short, was it had two components. Firstly, a user-centered orientation, so it was experience-based, and a collaborative change process, the co-design aspect. So it had 6 phases. I'm going to jump straight to the engaging staff and gathering experiences phase, where we would use lots of non-participant observation to observe day-to-day interactions between staff and patients about service processes, and understand their experiences both through those observations and also interviewing staff about their experiences of providing a service. And then we'd have a feedback event with the staff where we'd work with them through facilitated processes to identify what aspects of the service they thought needed improving. Then the next phase, we'd work with patients, similarly drawing on the observational data, but also we would conduct filmed narrative-based interviews of these patient stories. So it's very much a storytelling approach, and we film those, and I'll come on in a moment to talk about why we think the film is important in visualizing these experiences. Then again, we'd have a patient feedback event where we bring the patients and families together, share what has come from the observational data. We'd view together an edited version of the film of their experiences. And again, for a facilitated process, we'd identify the priorities that the patients and families thought needed to be addressed in the service. Then the 4th phase, the co-design meeting, is where we bring the staff and patients together for the first time. The patients would hear what the staff priorities were for improving the service. The staff and patients would then together sit and watch the patient film, the edited film that we made of their experiences. So we've moved from individual patients sharing their individual stories to the patients coming together and sharing their experiences as a collective, as a group, with the staff. At that co-design meeting, the staff and patients would then identify their shared priorities for improving the service. They would break into smaller co-design teams using design methods and tools to address those over a period of time, using iterative prototyping, quite creative methods for coming up with solutions and implementing those. And then they'd come back together at a celebration event. And the idea is that this is a cyclical process. This isn't a project with a fixed duration and end. This is a cyclical process. And so there are the key features: patients at the heart of the quality improvement effort, but not forgetting staff. Crucially important that we address both sides of that coin. And a focus on designing experiences, as I said, not just systems or processes. And importantly, where staff and patients participate alongside one another to co-design services. And so we've been working with this approach for many years now. There's a paper in the British Medical Journal in 2015, which looks back at the first 10 years of experience-based co-design. And there's been about 100 projects or so, over 100 projects now, in more than 8 countries. Here's one example from a township in South Africa. So experience-based co-design in a small way has been added, if you like, to the quality improvement toolkit. But what I wanted to do now was to pick up on the very specific point that Paul introduced about how do we understand and respond to the lived reality of patients. So all of these issues are very difficult to simply extract from a survey response or to do in a non-participative way. So we use very ethnographic methods. So as I mentioned, non-participant observation, storytelling, to really try and understand people within the context of whatever the design or quality improvement challenge might be. What do they do? Why do they do it? What are their physical and emotional needs, etc. So what I wanted to do was just very briefly pick out 3 of the methods we use. So firstly, as I've already mentioned, observation as a form of narrative. So the example I'm going to give here, in New South Wales and Australia and several emergency departments, they use experience-based co-design to improve the services in those emergency departments. I still think observation is massively underused in a lot of our quality improvement work. It can be done in quite a low-cost way, but bring real benefits and insights to what we do. This is a picture of a patient at one of these emergency departments checking in at reception. This is in Bankstown Hospital in eastern Sydney. And as you can see, a picture tells 1,000 words about this experience of a patient checking into this emergency department. The important aspect, and I'll keep reiterating this is the staff experience as well of that same moment, that same interaction in terms of the relational interaction between the staff and the patients. And in this particular project, the observation really showed up how problematic this interaction was because of the physical environment in this particular emergency department. So one of the co-design priorities that the patients and staff worked on in this particular project was about improving this physical environment to improve that interaction. So this is a photo at the end of the co-design project of how they've redesigned and redeveloped that check-in experience within the emergency department. But I share that as an example of the power of observation, of picking up these things that might otherwise be unseen and unremarked, but yet really improve the service experience. So that's the first sort of tip around methods. The second is around patient narratives and storytelling, and how we can use some of the concepts in service design within our quality improvement work. So, as I mentioned, we used filmed patient narratives in our approach. This is actually the poster from the very first pilot project back in 2004, which was in a head and neck cancer service in southern England, inviting patients and families to tell their stories on film. We create, with the patients and families, an edited film, normally about sort of 20, 25 minutes long, drawing across maybe 12 or 15 of the patient's stories. We bring the patients to that patient feedback event. This is a picture of the patients that just watched that edited film. Now they're sharing their reflections on the film, how it compared, contrasted to their individual experiences. This is all about the patients coming together as a collective group, so that when they meet the staff, they're not now meeting them as individual patients, but a group of patients with shared experiences. And then we use various service design techniques and tools to elicit what are the improvement priorities for this group of patients, in this case in a head and neck cancer service. So we might use some emotional mapping, other facilitated techniques to help them come together as a group. And one of the concepts and tools that's very useful, I think, in service design is this notion of touch points. What are the really critical points, the big moments, both good and bad, the positive and the negative? The moments of truth, the emotional hotspots that have really shaped these patients' experiences of a service. So we can use these to interrogate the patient stories, to find out what are those really important points where we really need to ensure that we're providing a good service. So example, breaking the bad news moment, when they were given the diagnosis of cancer, that's clearly a touch point for these patients. Another would be perhaps the mirror moment. So many of these patients would have quite significant surgery, these head and neck cancer patients. All the guidelines and protocols said that they had to be accompanied when they saw themselves for the first time post-surgery, but often the patients would talk about seeing themselves in the mirror when they were alone. And they spoke about that as the mirror moment. Another would be the fitting of the radiotherapy mask, which was terrifying for many of these patients. What could we do to improve those experiences, the mirror moment and the radiotherapy mask, etc. So that was the second, around the use of narratives and storytelling. The third is around visualizing these patients' experiences. And on the toolkit that I mentioned earlier, there's lots of tips about how you can interview and film patients and use those films in these types of processes. I just wanted to share two staff reflections on sitting down next to patients and seeing these films. So when you see the video and you can see the emotion and you can see what's happened, it's very hard to argue with an experience. You can't argue with that. It's their experience. If it's just written down, as it might be in a survey, for example, it's easy to dismiss. You see it. It has a much deeper psychological impact. Another one, film was a very important part of helping staff take a step back and have a look at what was really going on and see people they've been treating as patients, as just people, as human beings. It had a dramatic effect for the staff to suddenly see someone who they only previously perceived as a problem, seeing them from their face, hearing their voice. It really made a difference. So a really illustrative example of the power that these types of approaches can bring to empathy, really understanding, but also having the capacity to respond to those experiences. So just briefly, a couple of final slides. Fundamental features of experience-based co-design. This relentless focus on the experiences not only of patients, but also of staff. And importantly, the co-design part of this process is really important. The understanding the lived reality is necessary, but it's not sufficient in itself to bring about improvement. That comes through the co-design process, where patients and staff work together as partners on the basis of understanding that lived reality better to then make improvements to services. And that can lead to broader forms of value, for example, broader issues of well-being beyond just clinical outcomes. You need to maintain a focus on those two features, experience-based and co-design. That's more important than necessarily sticking very strictly to a set of steps regardless of context. It's about the fundamental principles. And it's the mindsets and behaviors that are encouraged and practiced through implementing the approach, particularly the co-design work, I think, around perspective sharing, dialogue, collaboration, empathy. That should become part of the way in which participants seek to improve services in the future. Much more importantly for me, around a mindset. And the approach, like many approaches, is very flexible as long as you stay to those fundamental principles and use, adapt, tailor it to your local context. The key is the process of thinking with these types of empathetic approaches. So I just leave you with one sort of key lesson, one final thought. I think we need to think much more critically about which quality and safety problems might benefit from being addressed through a participatory change process that focuses on patient and staff experiences. Not all quality and safety problems require this type of approach, but where they do, they must be part of this of a change process if we're not only going to understand the lived reality, but also be able to respond to it in an empathetic way by making improvements. And we can do that through some of the methods that I've very briefly outlined today. So thank you very much. There probably won't be time to answer all the questions and comments, but if you want to drop me an email or get in touch with me on Twitter, I'd be very happy to do that. Thanks.
Thank you very much, Glenn. That was spectacular. Are there questions that have cropped up, Tina, that we should pay attention to?
Yeah, there are. There was one quick question that can probably be answered with a yes or no, which was, is the head and neck video publicly available?
So the head and neck video is quite old now. It's 2004, 2005. If you go to the toolkit that I mentioned on the Point of Care Foundation website, there are several much more contemporary examples of the patient films that we use.
Great. There's also, since you mentioned sort of quality and safety, we have a question from Carolyn about what happens when there are failures in care, adverse events, and the TIF caps become adversaries. And do you have thoughts on how this approach might address that dysfunction?
So I think so we need to nip those things in the bud. I think it needs to be, we need to use these approaches much more proactively so that it never reaches that stage. One of the things we're interested in exploring here in the UK is we have real problems with our patient complaints. That by the time it gets to a patient complaint, those adversarial behaviours are really set in stone. We need to work much further downstream with these types of approaches to avoid those types of incidents, I think. Yeah.
And I think there's a similar question, well, a little different, but about sort of how do we normalize co-production within systems that are often paternalistic, and where there may be professionals who think it's their role to tell people what to do, and possibly people in society who accept that. And any comments on how you've seen that affected by this EBCD process? So,
yes, very short answer. We have to start somewhere. This is a very long haul. What I've observed in many of the organizations that have used experience-based co-design, perhaps in a pilot project, quite often they will, at the end of that pilot project, then roll it out to other services. I think there's, as with many QI approaches, there's always the question of scalability. But I think once people step into this process, it's quite difficult to sort of turn nations and stuff.
Great. All right. Paul, I will just check with you on the time. I think there are a couple questions still here that may be addressed in our next conversation. So
well, let's hold those and let's go on, because I think that what Glenn has laid out for us is a wonderful process that has been developed over a number of years in a number of settings. And I've had the privilege of working at Jönköping, Sweden, and in the course of my time there, I've gotten to know and appreciate the work that Mats Bojestig, who's the chief operating officer of the system in Jönköping. And one day, Mats said to me, "So can you teach young doctors about this co-production?" And I said, "Well, actually, no, I can't teach them about co-production, but I can invite them into learning how to co-produce healthcare service." And so he said, "Okay, so why don't you try that?" And so Tina and I began to think about how we might test this idea. And we invited a pilot group of wonderful physicians in primary care training. And we invited them to think together with us about the learning and the knowledge streams that are underneath the co-production of healthcare services, but in a way that hopefully would link to their own work and to their own daily activities. And we thought that a way to do that might be to invite them to learn with a learning partner. And in the course of that, we had a lot of conversations about learning partners and how to go about that and so on. But one of these young doctors was Lotta Arvidsson, and she was good enough to agree to be in conversation with us today and with me as we might explore a couple of questions here. But, you know, when we invited you, Lotta, to work with a learning partner to discover this lived reality of the person that we sometimes call a patient, what happened with that?
Well, you know, I've approached learning how to co-produce healthcare as a professional in many different ways. And this way with a learning partner has, I think, been the most helpful to me. And it has made me realize that what I've been previously doing in the way of person-centered consultations and evidence-based medicine, it's been in many ways good, but it hasn't been the same as co-production. And my learning partner, whom we might call Michael, is a man in his mid-70s. I asked a former colleague of mine to help me find a person with lots of experience in dealing with heart failure, since that was one of my main interests in medicine. But in reality, we never talked much about that, since that wasn't his priority. He very generously shared, both in face-to-face conversations, email, telephone calls, his lived reality at present, but also the past, his joys as well as his pain points with life in general, as well as with health issues and in his interactions with healthcare. And he joked that with 2 new knees and 2 new hips, he was full of spare parts, and he had accepted that his heart failure and its consequences would be a part of his life. And, you know, instead, Michael's main concern with his health was wanting to, you know, stop increasing his growing obesity. And he'd asked on numerous occasions healthcare professionals to help him with that. And in our meetings, he often got back to that he didn't get any help. And he'd been to see a nurse, he'd talked to many doctors, and every time he was asked, "Are you motivated? How much motivated are you? What are you willing to do?" He got a lecture and he got a brochure, and nothing of this really helped him. He was aware of this, but his main problem, according to himself, but which was never asked, was that he didn't know how to cook. And his lived reality was that he was rather recently widowed in his early 70s, and he'd never really cooked previously in his life. And learning to do this by himself, healthy food, to eat by yourself, it was just a bit too much for him to learn by his own. So it was lots of microwave dinners and frying and stuff. And he asked the clinic, you know, could you help me with the practicalities. But then he had just a long lecture that this is not healthcare's task, and he felt very scolded and embarrassed that he didn't know this life hack, if you wish. And no one seemed to know the story of his life or his reason for asking for this. And in our conversations, Michael suggested that it might have been very helpful to him to have a combined class of nutrition and learning the practicalities, and at the same time getting to know people, and maybe after the formal program they can make a lunch club and have some company eating. And actually, when we, as a part of the worksheets which you provided and we spoke about, we checked the evidence-based medicine and the local and national guidelines, and much of what Michael actually had wished for was to a high degree recommended, but it was never offered to him, and not to any person in my practice when I looked for it afterwards. We also looked at the very many letters of appointments and results that he had saved. He had a huge pile of them. And we spoke about these from his view. And in these summons, and I think this is actually a horrible word, it's just like, you should come to us and we expect to see you now. They were very oriented around the needs of healthcare and what suited us. They had very little information on what might he expect, how could he prepare, the length of the visit or anything like that. And I think a change of tone in these summons would be very helpful if we actually wish to level out some of the power differences and make this person feel welcome to us, which was certainly not the impression that Michael and I got from reading this. Another one of his major frustrations, where we spent some time making a process map, was how to get in touch with his GP when having questions. And we looked at this both from his view and from my healthcare view, and then we compared this, and this was really interesting both to him and to me. And his primary clinic has actually been granted lots of positive attention for taking extra good care of people in their 70s by giving them direct access to a phone number for coordinating nurses. But this didn't really suit him very good, because he would much rather have preferred to have a time to be called back and not to risk being in an inconvenient place when the call was returned in any time in the next couple of days. And also, he didn't want to talk to these nurses whom he'd never met in person. He wanted to talk to someone with whom he had a relationship. It could be a doctor, but it could as well be a nurse. And therefore, he didn't raise some of his most important questions.
It sounds like
some of the stories he told us.
Yeah, so it sounds like you and he had a lot of different conversations. But I'm kind of curious about whether any of these conversations on your own reflection caused you to change or to modify your own practices in some way. Are you able to help us understand that?
I think there certainly was, and I think that a key to this learning partner experience is that you work together. You work together on these worksheets. You really explore the system, the science of this person's main health concern, taking into consideration their lived reality. And when you really see what can happen when you do this together, it's so easy to really see and appreciate that healthcare is really a joint effort. And then this gets into your mindset, and that has changed how I think about my work and the relations I have with the people who come into my practice. And it's actually become difficult to imagine it being another way. But practically, I think that what I've built into my work is much more listening about the whole situation. And I try really to stop assuming that I know what my patients think, and actually ask what matters, how it is possible, what they prefer. And I've also much more started to ask for their own thoughts on how a problem or a situation could be solved before giving any suggestions of my own, and actually allowing some time for this to take place, because it's not always that easy for any of us, because we're simply often not prepared for this. We're not used to working, I think, in healthcare in this way. And in our case, this was a lifestyle issue, but it could just as well be, a treatment where this includes a lot of work for the patient, or where it doesn't fit in to his or her life or the situation. And I have really come to appreciate that the person's own solution might be very good and it might work very well, and we should often try this one out at least at first. And in any way, even if it doesn't work, it's very informative to me, because it's starting what's actually possible. It starts in the real situation. And this I have found is kind of a shortcut for me, because unfortunately I can't spend as much time with all the people I see as I did with my learning partner. But this gives me so many clues into the lived reality and their thinking and their medical understanding. And that's important also to me as a professional. And I think that had anyone actually asked Michael about his suggested solution, then they instantly would have been given clues to his social situation and needs. And even if it could be done the way he wanted it to, there would have been a different approach and a better relationship, and at least him feeling listened to, instead of being offered the same solutions over and over again with no possibility of the working because they were solving the wrong problem. And everyone getting just more frustrated. And I think I also have to admit that sometimes thinking that if the person only had more information and knowledge, things would be fine. But this experience working with Michael as a learning partner has really very concretely showed me that this is not necessarily the case, because that is not the problem.
Yeah. Well, I really appreciate your willingness to sort of share this little biopsy of your own learning and your own experience with this knowledge building. My sense is that as you describe what you have described for us, many others recognize that this is very accessible to them as well, and it isn't so impossible to imagine, but we have this daily reality that we have to face. And therein lies the work that we're going to have to do as we move forward in this series of overview presentations. But Tina, thank you very much, Lotta. Tina, are there questions or things that we should respond to before moving on?
There are a couple. There's one that came in very early, and I think, Lotta, I'd appreciate your thoughts on this, because I think it ties in very nicely to part of the story that you just told, which was about how, since self-care is really sort of where health originates, and 99% of health production is done by people and families. How do you have any thoughts on how co-production can support that self-care?
Well, I think it's really starting by asking people of how is this possible and is this wanted, not just adding work, which sometimes is not beneficiary, but sometimes is very much. And I think the only way to do that really is having a good relationship and being very honest and willing to have it, and also showing we don't have all the answers, and we certainly don't know the practicalities often, at least not as doctors. I think nurses do this better. So I think it has huge implications for self-care.
Yeah. And I think there's another question about sort of this issue of how do we voluntarily divest power from the health provider so that this can become a shared process. And I think your story is a beautiful example of how just that curiosity can lead to a whole different way of framing what the encounter is about and what your role is.
Yeah. Working with this has hugely given me so much more joy. And I think that I don't see it that I give him way more power. I think that that's not the issue. I'm not any less valuable to the patient. I'm actually much more valuable, to be clear, if this works out, than by providing something that's not of value to this person. It's much more fun.
Yeah, so Tina, we and Lotte and Glenn, we've been spending most of the hour here opening this idea of building a different knowledge base, an understanding of the people we sometimes call a patient. What are the take-homes, Tina?
Well, I think there's certainly a very strong take-home that we heard from Glenn about just the importance of observation, of understanding what experience is, and really diving deeply into that and involving the TIFCAPs and families and others as partners in that. And there were a couple questions about, sort of how do you get sort of the providers on board with that? I think those real experiences that he described so well really show how, just as Lotte sort of created a different shared vision of what care is with an individual, that can also happen with a health or healthcare team. But it does require that really delving into reality, and I love the distinction of sort of really thinking about experience as opposed to just sort of systems and processes, really understanding what the manifestation of those systems and processes are in real life for real people. And I think Lotte has shared a wonderful story that really highlights the importance of humility and curiosity, and being willing to engage with people on a very human level, and the incredible insights and great ideas that people have. So I think, as you said, this is just really a way to begin opening up this whole potential of co-production. And we've had a couple questions in the chat also about what about risk management and I think we just have to sort of keep exploring and keep learning with our patients and families, understanding their particular needs, and really understanding. There was another question early on about sort of what about more vulnerable populations, or populations where literacy might be a challenge. And there's been amazing work that we're aware of done, say, with people with serious mental illness, that really highlights that the capacity for co-production is probably greater than we think.
So, as luck would have it, last week, an article appeared in the journal Public Management Review. Now, that's not a journal that I regularly read, but what I found fascinating was here was this professor of public administration who actually taught about co-production of public services. And the whole idea of co-production has been much more fully developed in the field of public administration. And this article was an article by this man who had had a stroke a couple years ago. And he was now reflecting on his own journey of co-production as a person who was dealing with a stroke and the healthcare system as he was trying to imagine some benefit. And this is a short little article, but it's a wonderful set of insights that he offers us. And he touches on the sort of the critical bridge points between the theory of co-production and his lived experience as he was trying to cope with his stroke. And I've tried to put a bunch of references together here for you to look at later if you wish. I wanted to preview the remainder in the series that we're trying to put together. Our next session is in October 15th, and we'll be focusing on number 3, the current state, the sort of the as-is assessment of the system that has to be navigated. And so we're focusing on the green knowledge stream, the one that is another contributing knowledge stream in this co-production of healthcare. But we've got 1 or 2 more minutes. Are there other questions, Tina, that we should address before we break up?
I think there are a number of questions related to the experience-based care design, co-design process that I heard from Glenn that he would be very willing to answer things for which answers can't be found on his website. So I would encourage people to reach out. I think there are questions that I imagine we will continue to explore as we go through this series of sessions related to kind of some of the questions and those sort of power and relationship issues that we continue to see. So I think they're great questions, and hopefully we have answered most of them to people's and there's another call that I think would just be interesting for people to continue to dialogue about, which is, and now we're in a pandemic, and how do we make this happen, and what does the EBCD process look like when we can't actually all get in a room together anymore. So those are things that I think we'll all be thinking and learning more about, and we may have more to say about when we come back in October.
Well, I've deeply appreciated the contributions of Glenn and Lata and yourself, Tina, and our team that's been looking at the questions that people have had. Obviously, we're all dealing with another reality, this reality of COVID as we live and try to do what we do. I'm very grateful for the time that people have taken and for the contributions that people have made. Thank you again.